contraction, do not also accelerate to get your fetal heartbeat and the mother's BP. Okay, you for the first hour of the duty, if we have patient, you monitor for the first hour. So from 3 o'clock, or if our duty starts at 6 in the morning, you monitor from 6 to 7 o'clock. That's 1 hour. Continuous monitoring. And then you have to monitor 30 minutes for the succeeding hours. So for 7 to 8 hours, 7 o'clock to 8 o'clock, you monitor for 30 minutes. And then from 8 to 9, you monitor for another 30 minutes. Okay? And then the rest of the time, for the 30 minutes interval in between your monitoring, you monitor the fetal heartbeat and mother's blood pressure. Okay? Any changes above the normal and below the normal, you should report that. Okay. Fetal monitoring should be done or should not be done during uterine contraction. Okay, so during the contraction, you're not supposed to get the fetal heartbeat. Any abnormal action in the fetal heartbeat's initial action is to change the mother's position. Okay, so if the fetal heartbeat is below normal or above normal, you change the mother's position into left side lying. We will discuss that later on. Okay, why it's left side lying. And then make sure that you understand the latent phase, the active phase, and the transitional phase. When your doctor will ask, okay, what is the duration and how often that will be the frequency, the doctor will know that when the frequency is shorter, like this one, it's 3 minutes and the duration is longer. Okay, so you are now actually moving on to the next phase. Okay, next phase. And then internal examination, we call that IE, but in your book it's termed vaginal examination. Okay, vaginal examination is usually done by the doctor, especially in the private hospitals. During our clinical exposure in Parasonoxine, we allowed our students to do internal examination just for the sake of experiencing how to do the vaginal examination. But we don't do it to all students. Okay, maybe 1 or 2 students for each blocking will have an experience of vaginal examination. Okay, so your first activity is to answer the assessment and contraction monitoring. Okay, now if still in the latent and active phase of stage 1, assist the patient in ambulating in the area, but when there is premature rupture of the membrane, like the bag of water is already ruptured, okay, the patient is not allowed to ambulate anymore. So when you say ambulate, not allowed to walk anymore. In AMCB, patients who are in labor during the latent and active phase, they're allowed to walk inside the labor room. Okay, there's a hallway in the labor room, so we allow our patients to walk, but they should be assisted in case when they have contraction and they have the urge to push. But in Corazon Loxin, once we admit patient in the labor room, they're not supposed to go down their bed. So they have to be in their bed, not even going to the toilet. Okay, so what we do is we give them bedtime. Okay, but in BAMC, we allow them to go to the toilet, provided they're still in active or latent phase. Okay. In Corazon Luxin, because there are 5 or 6 beds in the labor room, and there's only one nurse or midwife that's attending to all of this, and then another nurse and one midwife was attending to 3 or 4 deliveries in the labor room. That's the situation. So they're very strict when it comes to patient ambulation. Okay, they're not allowed to go inside the toilet because there were instances wherein the mother has the urge to push, and then the nurse and the midwife found the newborn in the toilet. Okay, so that's why they don't allow ambulation. Okay, so if in transitional phase, that will be from 8 cm to 10 cm, we allow patient to do squatting. Okay, so one student will stand in front of the patient while the other patient puts her hand on the patient's shoulder, okay, at the back, and then you have to squat together with the mother, okay, just like this. So one student will be assisting at the back to support the mother, and this woman should be here in front, okay, that is where this pregnant woman will hold. Okay, but when your patient is big, don't try it. Kung alanganin, huwag na lang. Okay? You might use these other or modified or other styles for squatting. Okay? So this one is done in bed. And this is also a labor room which has this bar. Okay? So you let the mother sit and squat, okay, using this bar. Or if not, then let the mother sit and squat with the hands on the head of the bed. Okay, next. So when the doctor said, let's bring the mother to the delivery room, the assisting, we're still talking about the assisting student nurse. Okay. You assist the mother to remove the undies before mounting to the DR table. And then you, as the assisting nurse, you have to wear clean gloves. You put Kelipad, this one. And then there should be a pail at the end of the Kelipad to catch all the water and blood coming from the delivery. Okay, so in bringing the mother to the DR, we usually transfer them to the stretcher, and then from the stretcher to this delivery table. Okay, so once the mother is now transferred to the delivery table, you might want to notify the folks or the family members who are with the patient, and then ask them to buy ice. Okay, and the ice. So this will be used later when the placenta is out. That will help in the contraction of the uterus. So this is just a preparation. Okay. So if the mother is now mounted on the table, you assist the mother in lithotomy position. So you raise the legs and place it in the stirrup. Okay, so this stirrup, this black part, that is where you put the legs of the mother. Okay. So when you lift the legs, it should be both legs. So the assisting and the handling student nurse will lift the legs and position the legs at the same time. Okay. Then after that, when you have the mother positioned already, you do your perineal flashing. Okay, perineal flushing, we're using the 5% betadine solution. It's a betadine solution, but it has a lesser concentration. So we use that to clean this perineal area. Okay, so if you notice, we have 6 movement. No, actually 7. Okay, 7 movement. The first one is from the symphysis pubis, okay, or from the lower part of the abdomen to the symphysis pubis. That will be the first. And then the second will be on this thigh, or either of the thigh. That will be the second and the third part to clean. And then the fourth and the fifth will be the labia. And then the sixth in the vulva. And then seventh in the anus. Okay, you clean this part. Now, in an instance when you clean the number 6 part, okay, or the number 5 part, and your gauze had touched the faces, you have to change your gauze. Okay. So we're using the cherry balls. We call that cherry balls. It looks like this. Okay. So it's a gauze that is rolled into balls. Okay. So we use the pickup forceps for specific for this job, and then you clean the perineal area. Now there are also variations to this one. So what you see here is from left to right, or up, down, up, down, up, down. Okay. In the one that we are using in corazonloxin is when we clean the thigh, it's going out. Okay. So from the groin going out, groin going out. Okay. So there are some variations. So in doing this, you have to observe and ask what is the procedure that that hospital is using. So we are using here they're actually using one cherry balls to clean all of that. But if it's really it needs more cleaning, you can add, or you can use 3 or more cherry balls. Okay, so flush the perineum with water. So we're using this picture, and then use the cleansing betadine solution using this stroke. Okay, after that, you slowly flush again the perineum with water that is 2 rinse. Okay, so this is an example of the gauze that we are using in cleaning. Okay, then after rinsing, you again, the term that we are using is paint. Okay, in painting, we are using the 10% betadine solution. So it's more concentrated. It can kill more bacteria because of its concentration. Because we want also this perineal area to be clean. Okay. In AMCB or in BAMC, doctors will place or position the patient to the DR table, even if crowning is not yet visible. Head and baby is not yet visible. They will position the mother. In corazonloxin, they will only place the mother in the DR table when there is crowning. Pag wala pa crowning, okay, mother is still in the labor room, even if it's already 10 cm. Okay, so that's why in BAMC, if the perineum is not yet bulging, there's no crowning yet, okay, you have to wait. Okay, so while waiting, it's very tiring, and it's numbing to the legs to be in that position, in the tutumic position for a long period of time. So what you're going to do is to assist the mother to left lateral position. Okay, why do we have to place the mother in left lying position? Because it relieves the pressure to the inferior vena cava and it allows for better circulation. Okay, better circulation gives you better oxygen and nutrients passing to the placenta even up to that point. Okay, and keeps expanding the weight of the liver, which is okay. So that's the reason. Okay. Upon washing, instruct the mother not to push but to pant. Okay, so when you pant, that is rapid, shallow breathing. So it's okay, that's panting. That is to prevent rapid expulsion of the baby. Why do we have to prevent rapid expulsion of the baby? When there is rapid expulsion of the baby, there is not much support given to the perineum. You might have perineal laceration. Okay. So that's one of your instruction. Also instruct your mother once in this position, in the dichotomy position. Instruct your mother where to hold and when to push. Okay, so tell the mother to push only during contraction. So while waiting for the baby to come out, you have to monitor the BP and the fetal heartbeat of the baby every 30 minutes. Okay. Now, if the head of the neonate is delivered, you have to stay. As an assisting student nurse, you have to stay at this, beside the mother. If the expulsion occurs, you have to note the time and to say baby out. Okay, you only say baby out if the last part of the body of the baby is already out. So if the head is out, it's not yet time to say baby out. Okay, wait for the feet to come out and then you say baby out 10:15 a.m. Okay, so just take the time and then take note of the fetal position and presentation. So we have discussed the position and the presentation. Okay, so we have this cephalic vertex. We have a longitudinal line, which is a bridge. So for this one, this is front bridge, and we have the transverse, where the shoulder is the presenting part. Okay. Next is this one. So for the cephalic presentation, we have this type vertex, sinciput, brow, face, and chin. For bridge, we have complete, footling, and front. And then for the shoulder, we have the arm, the shoulder, or the trunk. Okay, so this is your vertex. So what you can see is here, the top of the head, or we call that the occiput. Okay, this is the face presentation or the brow presentation. This is the shoulder transverse presentation. This is front bridge. Okay, so if you're going to differentiate front from complete, okay, so when you say front, the feet is extended. Okay, it's extended. What you are seeing here in the opening is the buttocks. In complete bridge, okay, so you have the feet and the buttocks here at the opening. And then we have footling. Okay, so one foot came out first. So those are the presentation. Okay, what you see first or what comes out first is the presentation. Now, what is position? Of course, position is left and right, left and right. Yun lang naman. Okay, so if you're facing the mother, okay, on your left side is the right side of the mother. Okay, so that's why here, this is the right side. Okay, your left side, if you are facing the mother, your left side is the right side of the mother. And your right side will be the left side of the mother. Okay, gets na ha? We are basing the fetal position on the side of the mother. Okay, so if we have this vertex position, the presenting part is the occiput. Okay, it's the occiput. That's the top of the head or the crown here. Okay, so the occiput is on the right side. Its vertex, so we are using the word occiput. And then the occiput is in the posterior. What do you mean posterior? At the back part. Okay, because the face is facing the symphysis pubis. So the occiput is now at the back. That's why it's called right occiput posterior. Okay. And this one, right occiput transverse. Okay, the occiput is on the right. And then it's instead of facing up or down, the baby is facing the side. Okay, ang face ng baby dito sa side, so it is transverse. On this side, ROA, the occiput is still on the right, and the occiput is anterior. It's facing the symphysis pubis, and the face of the child is facing the anus. Okay, so the occiput is anterior. Gets na? Pag hambal anterior, it's in the front, posterior will be at the back. So the base here is the occiput. Okay, when you say it's cephalic vertex, so you're going to use the word occiput. Okay, so on the left side, it's the same. When the occiput is facing the anus, that will be posterior. When the occiput is facing the symphysis pubis, then that will be anterior. When the occiput is facing the side. So that is your transverse. Okay, so when you write it on when you document it, you are using this acronym LOA, LOP, LOT, ROA, ROP, ROT. For those nurses who are in labor room, in delivery room, it's understood when you say LOA. Okay, baby was delivered, female baby was delivered, LOA. So na-understood na yung LOA at 10:15 a.m. That's how you write. Okay, what about if it's breech presentation? How will you say the position of the fetus? We are using the word sacrum. Okay, sacrum. So it's the same. Just know where is the left of the mother and where is the right. Okay, that's the first word. Left or right. And then the second word will be the presentation. The presentation is sacrum because it's bridged. Then you state if it is anterior, posterior, or transverse. Anterior if it's up, posterior if it's at the back, and then transverse if it's on the side. Okay, for face presentation, for the face presentation, we are using the word mental. So when you write it, you don't write the word mental. So you write left, mental, and anterior. Left, mental, and anterior. So it's L, M, A, L, M, D, L, M, D, R for the right, R, M, A, R, M, D, and R, M, D. For social presentation, we are using the word acromion process. Okay, it's the acromion process here, but we are using the word scapulo for that. Okay, so that's scapulo anterior, left scapulo posterior, right scapulo anterior, and right scapulo posterior. Okay, so then you have three words for your metal position and presentation. The first word is the left and the right of the mother. Just identify which part ang presentation. Okay, left or right. And then if it's vertex, it's the word occiput. If it's bridge, sacrum. If it is face, mental. If it's the shoulder, scapulo. Anterior and posterior refers to the front and the back. Okay, next. So once the baby is out, the baby will be placed on the abdomen of the mother. So usually the abdomen is, or the mother will be wearing clothes, open as abdomen. That is to promote skin contact or the program of the government, which is the Unang Yakap. You will learn about Unang Yakap in your nursery exposure or clinical area. So here, as an assisting nurse, you have nothing to do. So just watch and observe the baby. If the baby is bluish or pinkish. And then you get or check the baby of the mother, assess the BP after fetal expulsion. And then the baby will stay there for about 5 minutes. If the baby is well and the upper score is good, that's okay. So you have nothing to do but to hold the baby if you are asked to hold. Okay. Nurses or nursery people will come in and also check the baby. For upper story, which you will learn in your nursery, the first minute of that should be done by DR nurses. So as the student nurse, you should also know how to do your upper story. But you will learn that in your nursery lang. Okay. So once the baby is out and given to the nursery people, palpate the uterus to determine the degree of contraction, and then wait for the placenta separation. So observe the signs of placenta separation. Actually, there are four. You have rising of the fundus to the level of the umbilicus, lengthening of the cord, and then you have the globular formation of the fundus and sagasha of blood. So those are your placenta signs. Now take note of the line of the placenta separation. So placenta out at, ano, 10, 15. So let's change this one to 10, 1. Okay. So after the placenta is out, you check the BP of the mother, and then you refer the BP to the obstetrician or the delivery physician. So you have to say, doctor, the BP is 110 over 80. Okay? The doctor will sometimes they will ask, or sometimes because they forget also, they have a lot of patients, they will ask you, is there oxytocin incorporated in that fluid? Okay, can you open that? So you have to regulate your IV fluid with oxytocin. But if the mother doesn't have any IV fluid, then you have to ask the doctor if you have to, you will ask the doctor if you will inject 10 units of oxytocin. So this is actually the standard. Once the placenta is out, oxytocin should be given to the mother. So it's injected IM on the deltoid muscle. Okay? So it's either side. You just ask the mother, but usually it's given to the left. Okay? So ask the mother where she referred to have the oxytocin injected. So this is the medication for healthy contraction of the placenta. And then remember the ice as you pass the remember to prepare. Okay? You take that and wrap it in a plastic or a cloth or ice bag. You can use ice bag also. And then place it over the abdomen of the mother. Now, if the doctor perform the episiotomy, that is widening of the vaginal opening to assist the passage with breathing, after the delivery of the placenta, the doctor will do the episiotomy, that is the repair of the episiotomy that was done. So this is your hand as an assisting student, and this is your hand. Okay, the one without the gloves. You open the cover of this vial, and then tilt the vial so that the handling student nurse can get or aspirate the liquid. Okay, so usually you will get 5 ml of liquid. Okay, so as a handling, you do not touch the vial, and as an assisting, you do not touch any of this part of the syringe. Okay. So after the episiotomy is done, the handle student and doing the aftercare. So you have to clean. You will have an assignment. Check the fundus characteristics and the level. So the fundus should be contracted. Okay, you check that. What is the problem if the fundus is not contracted? You will have bleeding. So you check that every 15 minutes for the first hour, and then every 30 minutes for the next 4 hours if the patient is still in the delivery room. Okay, monitor the lochia. Lochia is the discharges after delivery. After it can be saturated after 30 minutes. It means to say your mother is passing more of blood. So you have to notify your physician if your perineal pad is already saturated after 30 minutes. Okay, if there's no perineal pad, endorsing to the postpartum area. Check the mother's blood pressure. Okay. Activity 3 is drug study. And this is 4. Okay. You have to do your drug study of oxytocin and lidocaine. Now let's go to the responsibility of the handle of the students. So handle also do the labor watch. So I will do assessment. You will help with the blood pressure and then the pressure. And make sure to study the diabetes of labor. And the mechanism of labor, diabetes and symptomatic expulsion procedure. Okay, so discuss the stages of labor. We have discussed the diabetes. Okay, so what are the